So, slides, action, go. So, using insight to improve quality. And I think it's worth reflecting in terms of, I think, in real terms, relatively new to the NHS. I think 3 years still feels quite new. I still rely on other people to help me interpret it at times. But the reason I took this job is, for many, many years, I worked for private sector market research, then academia, then at Ipsos Mori for many years. And one of the things that we used to think at Ipsos Mori, frankly, was there's so much data there, and there's so much data that's not necessarily being acted upon. And so part of this has been for me to try and understand why that's happening, and then to try and understand what are those barriers and how might we get over them. So this presentation outlines the initiatives that we want to put in place at a national level, but to be really clear, it's about all of us working on this work. It's about all of us using insight and data to drive change. And that's where we want to outline what our role is as a national support and leadership role, and about how do we work with you to use this data. Okay. So I think from the most fundamental premise, any service needs to understand the people it serves. And to give a few examples, we need to understand how many people do use the internet. We actually know that 1 in 3 people over 65, social grade D&E, are on the internet. 2/3 of people are not on the internet in that group. Now, that doesn't mean that we shouldn't be moving towards the internet, but it's important for us to be aware about where they are. How do people use language? What we're extremely good at in health is using very complex language, and using language which isn't used by people who are accessing our services. How do we start to bring that understanding back in? And there's very good reasons for why we do this. So the key thing is, if we're to deliver on the 5-year forward view about engaging with people and communities, how do we really listen to what they're telling us? And how do we listen to different groups? I thought the patient panel was outstanding before. And then the question is, how representative are those experiences of a general population? It's about using all the sources of insight to drive change, not just one. I like surveys, with the 2% of you in the room that also seem to like, thank you, 1 or 2, thank you, we shall meet up for lunch afterwards in a small group. But, how do we use all the different work that we've got out there? And I think one of the most important things is, what does this word insight mean? So I reflected on this in the workshop I ran before, that for many years in the private sector it was a market research function. And the idea of the word insight was around the so what. What does it mean? That it isn't just about just collecting data. It's about understanding how do you translate that data into meaning. So in this room, we have 19 people with the word insight in their title. But we have close to 300 people who should be listening to insight. And the key thing for us is that it's back on what Jocelyn was saying, which it isn't just the patient experience manager. It isn't the analysts. It's about everyone seeing that the insight, the customer feedback is part of their job, from board to ward, that everyone is aware of what we're getting back in. But we're also, our role is to be aware of what do those different audiences need from the data. How do we communicate the data in a way that makes sense? And the other thing that so one message from this presentation, which we'll come up with time and time again, is you're using the range of different data sources. It's not binary, it's not surveys or friends and family test. It's not patient voice or focus groups. It's about using all the data to develop a picture of what's happening within your services. And I think one of the key reasons I wanted to show this slide, this is Daniel Kahneman, who's a behavior change expert, and he says the confidence that individuals have in their beliefs depends mostly on the quality of the story they can tell about what they see, even if they see little. We often fail to allow for the possibility that evidence that should be critical to our judgment is missing. What we see is all there is. Now, to translate that means that people who work in health and hear health language every day need to be aware of, well, do we understand how other people understand that? And a really good example on a piece of work that I did many years ago was around cervical screening. And DH used to produce a letter that was sent out and said, you are due to come for your cervical screening test, because uptake was going down. It talked about sensitivity, it talked about specificity. It was a letter that felt that it was designed from a legal perspective to make sure that DH was covered. Okay? And then we were commissioned at the time by Tower Hamlets to do some work, and one of my team at the time went to do the first interview and said to this lady, have you ever been for cervical screening? She said, no, I've never been for cervical screening. And then we said, have you ever been for a smear test? And she said, yes, I regularly go for smear tests. And the reason I choose that example is it's about language that people understand, not that we understand. And all you need to say in that letter is, you are due for your cervical screening, you may know it as a smear test. And that's about using, that's why it's so important. That's why I believe it's such an important thing. And it isn't just about what people want, it's about understanding. And sometimes we think it's all about the want. We know that people want long consultations, but we know we can't deliver that. How do we communicate that? We know that people in waiting rooms who have to wait for 8 minutes rather than 5 minutes, but we tell them they're going to have to wait for 8 minutes, have a better experience than the people that have to wait for 5 minutes, but we don't tell them. So it's about using evidence all the time. And one of the things is, how do you actually communicate this to people, that where's the value? And one of the things, it's really difficult for this, and I think how does doing the research make a difference? But one of the things is, what happens if you don't use insight? And this was a piece of work from many years ago in Blackburn and Darwin, which says, for those of you at the back, people die on average 8 years earlier in Blackburn with Darwin than in other parts of the country, so we're investing in your health. And the public health people that commissioned this said, well, this will do it. This will stop people smoking and drinking. And they didn't test it in advance. And then they did some testing afterwards. And the first comment was, and the word rubbish, by the way, has been sanitized for this audience. It wasn't quite that language. But it's a really good example of why is it so important. What effect would that campaign have had? Did we put it up in the right places? Did we understand where people went for this information? Did we understand that in GP surgeries, people don't read leaflets and posters because there's too many of them and they get confused? And how do we communicate in clear ways? And that's why I think it's so important. And the next stage is, where are we now in this? And I think it's so easy to forget, and I think Jocelyn focused on this morning, about in what an exceptional position we are when it comes to patient-generated data. That if you go internationally, the NHS is seen as one of the absolute world leaders in this. We have a wealth of data. And I think Jocelyn is right that this talk today is not about how do we collect more data. It's about how do we use what we've got. And that's a really clear message that we're trying to get out. Back on the surveys, I'm going to do a show of hands. Who uses survey data in this room? Anu, you're my director. You must put your hand up. Thank you. So, surveys, the key thing is, why do we do surveys the way that we do them? Using social science, robust and rigorous methods. We have to start realizing that some of the data we produce, what's it for? If we're comparing one service against another, we need to be absolutely sure that we've employed the best methods to try and understand that it is better or worse than something else. If we were doing this in medicine or clinical work, we wouldn't give something to a few people who were self-selecting and say, let's see if it makes them better, and then we'll generalize that to the population. It's an incredibly rich resource that we have. 1.5 million people every year we hear from. I wanted just to have a quick word on the staff survey, because one of the things about these rooms is sharing good practice. And the staff survey, I know CQC are here. CQC would argue that the staff survey is perhaps the richest source of information on the quality of trust than anywhere else. So whilst we have patient experience data in this room, are you meeting up with the person that uses the staff survey data? So one of the networks that we heard about was 2 people caught the train back together. One of them ran the staff survey, one of them ran the patient experience. And in the 2-hour train journey on the way back was, how do we do this together? How do we work together? because both sets of data are equally important. If you think about a member of staff will see how many episodes of care within a year, as opposed to a patient that will see 1 or 2. And again, one of the key things for us is it's not about thinking, is the data good or bad? It's what can we say about it? If we're looking at the CCG assessment framework, we need to be absolutely clear that the data is sufficiently robust and rigorous for us to be able to use that. But they're not perfect. One of the things on the Cancer Patient Experience Survey that someone said to me, it doesn't tell me why something's happening. And the answer is no, it doesn't tell you why. It really doesn't tell you why. And that's when it tells you where you are. It tells you where you are now, it tells you where you are relative to before, and it tells you where you are relative to others. We know that on the GP patient survey between CCGs, you have as much of a 35% difference in overall experience of access between CCGs, not even between practices. Now that's the thing that drives the change. How do you go and find out why? What's happening? And that's where you use some of the other methods. But there are flaws in them. There are flaws in every data collection. Nothing is perfect. So the Friends and Family Test. So we've been working at NHS England on the Friends and Family Test for 3 years now. And we could talk a lot about the experience we've had in 3 years. And whilst I have the opportunity, just to say a massive thank you to everyone in this room who has worked on this program, because to meet 18 million responses so far is just extraordinary. I think we can't quite understand the scale of what's happened. It's absolutely extraordinary. And what is it? It's not a survey. It's a feedback mechanism. When we do a survey, we go to a sample of people, in the same way that when we do political polling, we go to a sample of people. I'm aware political polling might not be the best example. At the moment, you can ask Ben about this when he hears later on from Maury. But we go to a sample, but we don't give the opportunity for everyone to provide feedback. So what for us are the 3 most important things about the Friends and Family Test? One is it's for everyone to be able to provide feedback if they want to. That it's closer to real time. We don't have, on the PROMS program, we often get the data back 15 to 21 months after the actual episode of care. And when you present that back to a team, you'll often get, well, yeah, that was poor, but that professor's retired, we've changed the team, we're not there, we don't trust it. And actually, it's about using both data sets together. And actually, what is so striking for this is that, and it's the work that Jocelyn and Glenn Robert have done in the past, which is the closer you are to the ability to change, and the closer the data is, the better chance you have of doing something about it. Because you know what was happening. You know what was happening that week or the week before. So just to reflect on this on the Friends and Family Test, some of the initial things were it should be comparable data. It should be about variation in care. But actually, it's not comparable data in the same way that the surveys are. It's not. It's done in different methods in different places, but it's about what Jocelyn was talking about the local ownership of the solution, as witnessed by the team we've just seen up on the awards, that we have tried to say it's a national initiative, but it's locally determined. How you do it is the best for your provider, your trust, your practice. You make it work for you. Okay. And as Jocelyn said, we also have huge amounts of other data. Whether it's qualitative data, whether it's patient opinion, whether it's increasingly social media, which we need to be looking into, there's huge amounts of data out there. And again, the message is, it's not that one data set is better or worse than another. It's about how do you understand what you can learn from them rather than dismissing what you can't. And I think, again, what we heard before is that actually one of the things that was most striking for me when I was working in the past on patient experience was a story that someone told in a trust. And it was around mixed-sex accommodation. And I remember an audience like this, and it was almost split down the middle with nurses on one side and doctors on the other. And we'd done some work around mixed-sex accommodation. And a woman had come into an ITU in a coma. And she'd woken up 3 or 4 days later, and in that time, she knew that she had been naked at some point because she was in different clothes. No one spoke to her when she woke up. No one said, whilst you were in a coma, 2 female nurses came in behind a screen and we changed your clothes. Are you okay? No one spoke to her. So for the next 3 nights, she didn't go to sleep because she was so scared about what would happen to her. Now, when we told this, one side of the room with the nurses you could see were nodding and doing some of the looks that I've just seen there. And then a doctor put his hand up. And not to say that all doctors do this, we've seen that actually, but a doctor put his hand up and said, does it matter if she's better? Now, that story I tell, I think, is more striking. The things that we see from patients, the patients panel this morning, is more striking and is more likely to change behavior. But it's even more powerful if we know it happened to 1 in 5 people. So again, it's about what do we want the data to use. We know that boards are using patient stories to generate change, but we also say, well, where's the survey data? What's the scale of it? Where do we need to be making our moves? On the GP patient survey, there's a huge access. People think surveys don't do much. Access to GPs is a key initiative at the moment. It's being driven by the GP patient survey. The national director who works on that looks at the patient survey on an almost weekly basis. So it's about being clear what we need the data to do. So we're in a fantastic position, I would argue. We've seen from some of the awards, and we'll see some other awards about what work is already being done. There's still things that Jocelyn's talking around. I think one of the key things is data into action, noise to signal. I think often it can just feel like noise coming into the system. And there's a few things that we're going to try and do from a central position that we need your support on, we hope to work with you on, about moving from data into action. So we want to move the NHS from a data collection organisation to an organisation that sees data as a way to improve and learns the skills to do so. Put simply, the NHS needs to be much better at listening and acting on the information it collects. And sometimes they are small, incremental changes. Sometimes they are more seismic changes by listening to what people are telling us. But both are valid. So, how will we get there? One of the key things that I've learned in the first 3 years is that someone somewhere in the NHS is doing a far better job than we probably are at the centre. How do we share the great practice that's already going on? How do we get people to listen to the awards? Someone at the East of England event that I attended a couple of weeks ago said, I was at an event a year ago, we pinched this idea, it's working really well. How do we get that going, about good practice going around the system? Well, there's lots of great examples, and perhaps how do we create this appetite in colleagues? And I would argue that this room is almost, we would say, probably the outliers in terms of this. How do we get our colleagues back into our organisations to listen to this data in a way that we probably already do, but we need to get them on board with listening? And again, one of the frustrations I told, people may have seen the Roy Lilly column this morning. Did anyone see the Roy Lilly column? Yeah. Roy Lilly has chosen a survey this morning that is the ropiest survey I have seen for the past 10 years. He says he doesn't like surveys, but because it kind of matches what he's saying, he's quite fond of it. So how do we become discerning about what data is telling us and what it isn't telling us? How do we understand methods? So perhaps the most important thing that we wanted to talk about today, it's not an announcement, it's an initiative, is how do we create this insight network? And we've worked on the principle that you're here. We've worked on the opt-out principle in terms of behaviour change, that once you're here, we think you're part of it until you tell us otherwise. How do we get this network going? And how do we save money? We're seeing from the vanguards that 3 or 4 people are doing something on urgent and emergency care. It's very similar work. Now, that might be okay. We know that local work is important, but how do we get that shared practice? You'll see the workshops that colleagues from the Insight and Feedback team have been running today are starting the how do we get the knowledge out there. And we would welcome ideas from you on what else do you need to know, what can we help you with in terms of insight and feedback. We're also aware that we're very poor at presenting data. We often make data esoteric. There's a nameless professor that I work with who said, well, if people don't understand funnel plots, they should just learn. Or we could say, what do they understand? How do we get that data across in a better way to drive change? Now, I am quite fond of confidence intervals and p-values and powers of samples, z-test, t-test. I am unusual, but it is a skill set. And how do we translate that into other ways? Is there someone else who's pointing at someone else who also likes that stuff? Good, we shall talk afterwards. No one else should listen. So how do we get better at presenting data? Now, this is a slide that I wanted to show. So people may have seen this slide before. If you have, please don't shout out. But this is a patient with Parkinson's disease who presented this slide. And this is around her story. And she was explaining why self-care was so important. And there's a red dot in there. There are 8,760 blue dots. What does the red dot represent? Who said that? Sorry, say that again. That's the time that she spends in a year in clinical care. The other 8,759 hours is self-care. Now, how do you make the argument for self-care? You show this type of data. You drive impact. It isn't a graph. It isn't a funnel plot, but I've never forgotten it. How do you drive that change? And then again, you'll see outside we've got lots of rolling screens about how do you get the data across quickly? How do you use infographics? How do we make the data come alive? And that's something that we will be trying to work with you on. One of the things that we're going to be doing over the next year, again with DH and CQC, is looking at this central data facility, because we know the staff survey is over here. We know that the inpatient survey is over here. We know the GP patient survey is over here. So we will be coming to you to ask, what do you need from it? We've done some work on the GP patient survey already, working with practice managers and users to make it a site that's user-friendly. So we need to be living by the principles that we go by, which is using insight to drive the products that we design. And again, we would welcome thoughts on this. What is useful for you? How do we pick up the piece of work that's being done in this CCG and also communicate it, the key findings, out somewhere else? Again, related to the Insight Network, and how do we drive that? Because we're aware that it can feel fairly isolating. It can feel fairly isolated at our level, where we're not always clear on what's happening. So we need to be building up that shared working with you. Something that was also mentioned, I think by Katie in the first patient panel, which is around coordinated care. We're very good at measuring individual services. Was your GP okay? Was your inpatient service okay? Was your social care okay? We don't know. We know that the transitions are where it's not okay, but we don't measure them. And one of the reasons we don't measure them is because when we draw what we call a sample, we're not allowed to know which services someone's in receipt of. We just know the service that they've actually got. So one of the things we're working on is how do you get that data in the background? And again, we need to be working with you and piloting how do we do this better. So Katie is being asked at the right moment the right questions because we know where she is in the system. And in the future, that's a much more cost-effective way where we can target questions in a much better frame rather than sending the same survey to everyone regardless of who they are. And the other thing that we need to be thinking about is how do you link insight to clinical data? Because many of the surveys we do, we ask lots and lots of information in the background around long-term conditions. But if we knew lots of information about someone behind, so we've started this work on the Cancer Patient Experience Survey with the National Cancer Intelligence Network, where we are starting to realize that, for example, on cancer, if you go through A&E in your diagnosis, you will have a worse experience than if you enter the trust through other sources. So that allows us to start looking into what is happening there. So this is a key area of work for us over the next couple of years. And there's lots of other techniques which we want to bring. The behavioural change, which I'll just focus on for a second, there's a great experiment that's been done around did not attends in hospitals that people may have not seen about the text messages. Sometimes the problem with market research is asking people. That you don't just say, what do you want? Sometimes you do trials to understand what works. So this was a piece of work that did DNAs. They said things like, you're due for your appointment tomorrow. you're due to attend. That's all it had in the text message. Then there were various other messages, social norm messages. Then there was something around, it will cost this much money to the NHS if you do not attend your appointment tomorrow. And there's a statistically significant increase in the people that attended who received that text message. How do we share that out here? How do we make sure that everyone is aware of that knowledge? Again, observation work. I did a piece of work in A&E many years ago where we interviewed doctors in advance, and then we observed their actual behaviours. What they told us they did, I feel like I'm picking on doctors, apologies. What they told us they did in advance was not what they actually did when they were on the ward. And it's reported in actual behaviours. And again, it's understanding the relative strengths and cons. The other thing is we need to start thinking about moving from paper to digital. This is not to say that paper is the wrong methodology or the right methodology. It's about when can we use digital to move faster, to link data quicker, and to understand data quicker. And that's a clear direction of travel for us. In PROMS in particular, we're looking at this and how do we get this moving. In something like GP patient survey, we can't do it until we get that database of people with emails. So there's some things we can do which are reliant on other initiatives in the NHS. And then again, how do you understand how payment can be attached to patient experience? And this is always controversial, but how do you make patient experience as important as other data coming into the system? And this is one of the ways you can do it. Now, it's not without controversy, but it is one of the ways you can do it. And last week, we announced the introduction of a quality premium on the overall experience of making a GP appointment at CCG level. And we will see what that does or does not do to drive behaviours. Because it has to be, in the behaviour change, it's not just the nudge sometimes or the hug or the kiss. Sometimes it is other ways that we need to nudge. It is other ways that we need to intervene and incentives. So I'm going to starting to wrap up now, but the thing is, it's all our business. The one thing I'd say on this all the way through is we haven't talked much about suppliers, but there's suppliers here. I've worked on the supplier side. They know so much about what they're doing and how can we tap into some of the resource that they have and that they've experienced in other areas. So, moving on now to, if we're going to do this, we need to evaluate it. We need to understand where we are. There's lots of things about where we are in delivering these initiatives that we've talked about. But there's also something about us using data to understand if we are making a difference. So, back on the keypads, if you can. Okay, so this is a question that we put in the staff survey. So it'll be interesting to see, we're going to show you the overall results. So is patient or service user experience feedback collected within your directorate or department? Yes, no, don't know, not applicable to me. Okay, so let's go. Okay. Surveys work, don't they? Isn't that interesting? You are representative of something. You are representative. 67% and 66% saying yes. And we're starting to see some change. 2014 to 2015, we're starting to see some change on this question. It's small change, but it has to be the right direction. Okay, let's try another question. So the next question is, to what extent do you agree with the following statement about feedback from patients or service users? I receive regular updates on patient service user experience feedback in my directorate department, e.g. via line managers or communications teams. So strongly agree. Now we're changing the order. One of the things you do in questionnaires is you try and change the order to keep people awake. Strongly agree at the top. Disagree, neither agree nor disagree, agree, strongly agree or don't know. Okay? Let's go. We'll move on from the representative bit. So work to do. It's not the regular updates. What are people saying here? And then one of the things we need to do with the staff survey, so here's the job. How do we go away and work out different groups within the staff survey? And that's the next task. How do we work out different groups? Because these data sources are just a mine of information. Okay, let's do the last one. And I think the last one is potentially the most important. He said leading the question. But let's go to the next one. So to what extent do you agree with the following statement about feedback? Feedback from patients or service users is used to make informed decisions within my directorate or department. Okay, again, we're starting with strongly disagree. Let's go. Okay, again, so this is the key one, really. This is the key question that we need to be working on collectively, which is not just the collection, not just seeing it, that it's been used. So that's the one that we'll be using to try and understand where we are within the NHS. A quick word on the staff survey again is that we've managed to triple the sample on the staff survey in the last 3 years, from 100,000 to 300,000. And again, that was done through using online and sensors, so it's about thinking what we can do. So I would send this audience away and us away that this is the challenge that we all have to work on. And I imagine the award winners would be saying, that's what we do. It's about the decisions that we use. Okay. And then finally, we talked about this, Anu showed this, the public are dividing about whether it's easy to give feedback. Again, these are other things. It's not just staff, it's about the public and understanding. There's other question on this, which is, do they think it's being used to drive feedback? Not publicly available at the moment, but it will be soon, and we will make people aware of that. So this is where we need to try and get to. And this is how we'll be evaluated and judged. So for me, just reflecting on Jocelyn's presentation and the patient panel and the awards, is that there's huge amounts of really great work being done in this area. There's huge amounts. But I would argue that we're not really getting every ounce of value from what we already collect. And today is not about announcing a new data collection. It's about how do we just continue to work better with what we've already got. 18 million responses from FFT is quite something. So how are we making sure that we're using that data? So for me, if people are taking the time to feed back, people are taking the time to give us what they thought of their service, that's one thing. It means nothing if nothing is done. So we hope that today is the start of working with you more collectively with our role as a support, helping, leadership in some areas, but it's about working with people. I think it's lunchtime. Thank you very much.